Eric Wallis, welcome to the show. Glad to have you here today.
Glad to be here. Thanks for having me.
Oh, you bet. Absolutely. So you're the Senior Vice President and System Chief Nursing Officer for Henry Ford. Is that correct?
That is correct.
Awesome. You want to take a few minutes to tell our listeners a little bit about your journey that you took throughout your career to get to your current role?
Well, I always tell folks I won't go back to my first days as a brand new baby nurse, but I've been very fortunate throughout my career to journey from the time of being a bedside nurse in med-surg units and spent most of my life as a critical care nurse and at the bedside. But pretty early on, figured out that, if I wanted to actually make a difference in this profession and make things better, not just for the patients, but also for the people that I worked with, trying to take care of patients, that stepping into leadership was probably the most effective way for me to do that. And so pretty early on, had the opportunity to step into a nurse leadership role. Had lots of really amazing mentors along the way that thought that I had some amount of talent or potential. And so they kind of guided me along my journey, and I've had the opportunity to work in both, nursing leadership roles as well as hospital operations roles, COO, CEO. Thankfully, in 2021, was given the opportunity to step in and become the first full-time chief nurse executive for Henry Ford Health as we were kind of in the midst of the pandemic. And so the last 4 years have been spending a lot of time trying to, build some structure and process and really helping our health system grow and helping our nurses across Southeast Michigan, have the resources and tools they need to take great care of our patients.
Yeah. I mean, stepping into a leadership role at the peak or onset of the pandemic, I'm sure it had to be a wild and crazy ride. Anything in particular stand out to you as you sort of led your teams in the workforce at
You
Henry
know,
Ford during that time?
One, I'm just extremely grateful for the, amazing people that we have that lead at the bedside. Not only our nurses who are taking care of patients, but our frontline nurse managers just do an amazing job. And through that time, and as stressful as it could possibly be, they did a great job of one, taking care of each other, taking care of their team members, and really being willing to escalate and elevate the things that they needed. And so I think our nurse leadership team did an amazing job, and we dealt with a lot of kind of things you never expect come
Sure.
along in your nursing career, but being agile, listening to the folks who are doing the work, and helping to kind of move the organization forward, I think is things I'll never forget from that time frame. Because yes, we had a lot of hard things that we did, but we also had a lot of, I think I call it, big progress that we made during that time too, because we knew we had to do things differently.
Yeah. It seems to be a hallmark of a lot of healthcare leaders in general. It's the two things that you focused on. One was gratefulness, and two was listening. Right. So, and maybe that leads us to a little bit about the virtual care models that you all have released. So, maybe talk me through the journey, how you arrived at that, and what you're currently doing.
Well, I think the important thing about that is, and to your point, is trying to listen and kind of think through some of the big challenges that we have in healthcare today. The reality is, nobody is coming to hospitals and healthcare systems and saying, "Gosh, we really think that you guys are overworked and underfunded, so let's pay you more." And at the same time, we got a workforce that has just come through, hopefully a once in a lifetime event. People are burned out, they're tired. We saw, large numbers of folks who were kind of at end of their career decide, you know what, good, I'm good. I don't need to go through this again. So I'm going to step out of the workforce. And so I think, our system, like a lot of them around the country, came out the other side of the pandemic going, gosh, one, we got a really young workforce number, and two, we got a workforce that hasn't done a lot of this stuff the way that we're trying to do it now. And so we got to figure out, how do we reinvent healthcare to still make it attractive to them? How do we support them for many cases as they enter into practice without having had the benefit of, what we would probably call the traditional journey through nursing education? And so we started to look at, what's out there and how do we take advantage of this boom that we have right now in folks that are investing in artificial intelligence and, tools that can actually help to do some of the work. I'm very excited. I love technology. I love where we are in healthcare, but the reality is, for the last 20 years, every time we talked about a new technology in healthcare, what it did was it made documentation more complete. It was places where folks had more to more boxes to check, or it helped us to get paid more accurately, et cetera. So it really just added to the burden of the team member and the caregiver at the bedside. We're really at a moment right now where we got technology that can actually take work away from our bedside team members and make their jobs easier. Our job as healthcare leaders is to figure out how do we deploy it, so that it's actually useful to them, as we go forward. So as we started to think about that, and our health system has a line on our system strategic plan that is, how do we reimagine work? How do we think about work differently as we go forward? And so, one of the things that we started to look into was, how do we use these virtual care models, that started to pop up during the pandemic when, frankly, we couldn't always go into a patient's room. But how do we bring that to scale, and how do we actually use that to think about work differently? I think the reality is, nursing in this country has probably not really invented a new model of care in about 70 years. We've reinvented team nursing, we've reinvented primary care, and all these other models, but we haven't really tried anything new for a very long time. And so, ultimately, what we did was to come back, look for some partners in the technology space that we thought, were kind of like minded to us, and thinking about how can we use technology to reinvent the way care is delivered. And that allowed us to sit down with some of our bedside nurses and say, "Hey, let's have a conversation about, what are the things that waste your time, that, if someone else could do them, that would make your life easier. And then two, let's think about, if we had a camera in these rooms and someone was partnered with you virtually, what would top of license work look like for you? And maybe what would top of license work look like for the nurse or the team member who's working virtually?" And through having that conversation with our bedside nurses, we kind of came up with what is our virtual care model that we're starting to deploy at Henry Ford Health.
Oh, that's terrific. And I remember height of the pandemic, just usage of telehealth, platforms sort of skyrocketed. We'd actually look at adoption rates or trends for e-commerce versus physical brick and mortar store. And then all of a sudden, I think when we saw reimbursement rates change for in-person versus virtual, you sort of saw it recede a little bit. Did you all work through any of those adoption challenges or patterns, or did y'all maybe start your journey a little bit more deliberately post-pandemic? Maybe walk me through a little bit how you all
Well,
sort of navigated that.
yeah, and I think, as a large integrated delivery system, clearly we had gone down that path on the ambulatory side, right? Where we saw big adoption and patients being willing to do some specialties, more virtual care, a little bit in the
Sure.
primary care space, certainly in the behavioral health space. So we had an entire work stream around virtual care in the ambulatory setting. So this idea of bringing it into the acute care setting was a little bit different, and required, I think, some different thought processes. But at the same time, we didn't want to run these as two completely separate things, and so
Sure.
we've had to make sure that we've built strategies and structures so that we're staying connected, because ultimately these things start to overlap. We have very intentionally moved away from calling this virtual nursing, because virtual nursing is a use case. It is not the sum total of what we're trying to do. What we're really trying to do is reinvent the way that acute care is delivered. And so when you start thinking about use cases beyond nursing, there's physician use cases, there's pharmacy, there's case management, and really whatever you can imagine, it's there. And ultimately making sure that we're tying these together so that if we build a structure where, we want some of our highly trained specialists that may be at our academic medical center to be able to do consults at one of our rural hospitals. We got to make sure that that fits in with the schedule that they've also got, maybe to be doing specialty consults on the ambulatory side virtually. So how do we weave these things together so it's not disjointed, and we're
Sure.
not, making things more frustrating for our providers in that space? So it's definitely something that we're trying to be very, I'd say, intentional and thoughtful about. This inpatient model has to also sync up with what we're doing in the ambulatory space.
Very thoughtfully done. I think the one thing that's been consistent is you've talked about this need to reimagine how work is being done. Been done the same way for over 70 years, and it's not an isolated use case. And so you're fully unlocking the true value of this capability. And again, listening comes up from you quite a bit when talking to and engaging your team. So maybe walk me through the process that you went through in selecting the technology vendors that you chose to partner with, because I'm assuming listening was a key part of that for you and your teams. And And just how did you figure out which ones were actually listening to you all as opposed to kind of showcasing their views of the world?
Yeah. I think it really started with, from the very beginning, one of the stakes that we put in the ground through talking with our teams was that whatever technology we chose to adopt couldn't add to their work.
Mm,
So, meaning we talked to several partners that when you would talk about their models or how they will work, or frankly, as we talked to some other healthcare systems about how they were standing up pilots around virtual models, a lot of times it involved, well, the nurse has to go get something, an iPad, or the nurse has to go get a camera that's on a rolling cart, and bring it into the room. Well, ultimately, that just means that they've got one more thing that they have to do to try to use this technology. And so, pretty quickly, we kind of narrowed down on we were looking for a partner that had the ability to deploy fixed cameras into the patient rooms, so that it was always there. It was part of the I call it the healthcare room of the future. Number one. Number two was that partner has to be able to make the technology function in a way that it doesn't disrupt the patient, and it doesn't require
mm,
somebody in the room to do something to be able to bring that virtual team member into the room. And so, believe it or not, finding a partner that was able to actually control the television virtually or remotely, and then when the interaction was done, put it back to whatever the patient was doing, before the virtual team member stepped in, eliminated a lot of technology. And so, ultimately, we were fortunate that we landed on a partnership with a company called Care.ai that is now part of Stryker, that was able to meet kind of all those needs. Where we got to work from there was just working with them and working with our nurses and starting to say, okay, how do we want this to function, and how do we make sure that technology is working for our team and for the patient, and not having our team members kind of work around the technology.
well, that's terrific. So let's talk about change. So that sounds like the one thing that's been constant, I guess, in your time since you took on the role, really. But obviously, when you think about changing the workforce, how work gets done, especially if it's the models have been in place for over 70 years, maybe walk me through the change management process you went through with your teams. Where did you see resistance? Where did people embrace it? And more importantly, what did you do to help lead your teams through it?
So as you would imagine, right, anytime that you walk into a unit, or we identified a couple of units that we thought would be great pilot sites at one of our hospitals. And, the first day you walk in and say, hey guys, we've got this great opportunity. We want to completely change how you do everything. And oh, by the way, we want to do it with a virtual team member. There's a lot of skepticism at the
Sure.
beginning of that conversation, right? Because this is not how we have done things. It's not how people are educated. And frankly, in healthcare, we are trained that whatever we learned in school was the best way to do it because it's evidence based, and that's the only way we should ever do things. Immediately, we start changing that on graduation, but it's the principle that's beat into us. And now we're going to talk about and do something that maybe there's not a huge evidence base behind yet, but we're going to actually be creating that. And so, for us, it was very much about how do we create a committee of some of those team members, people who are both skeptics and people who are very interested in this, to come together and work with us, work with our technology partner, and again, actually design the workflows. One, it's like I said, we started with, what are the things that we're trying to solve? So that kind of concept of, of future back thinking. What do we want this to look like when we're all said and done? And let's work backwards from there. And so ultimately, it was our bedside nurses who told us what use cases they wanted us to work on first. They're the ones who work through with our partners on how that workflow should go. How do you have that interaction? Who texts who or who calls who? How do we work back and forth? And then
Wow.
the concept of running a pilot for about 9 months to make sure that we not only work through some of the things that maybe we didn't anticipate, but also start to think about what are some new use cases that we think have some value, and starting to test those out. Ultimately, I think what we learned in this, and my chief nursing informatics officer said this, and I will never forget it. Pilots of technology simply tell you, does the technology work or not? Eventually, if you want to find out if you actually can generate value out of something new, you actually have to take it to scale and see, does it actually perform the way that you want? Can it actually change outcomes? And so we went through, and we said about 9 months of pilot. We saw positive variance in the outcomes that we were tracking, but ultimately we knew that we had to take this to full scale to say, is it really going to help us achieve what we want to?
That's terrific. So you talked about looking at the metrics to understand the outcomes that you're driving. Could you care to share maybe some of the key metrics that you all are trying to monitor at the system level?
Yeah, so we're like a lot of other probably healthcare systems, right? Balanced scorecards. So we get everything from finance, quality, engagement,
Yep.
kind of metrics that we're looking at. Ultimately, in our pilot stage, what we saw was reduction in nursing turnover. We saw metrics, tracked metrics that were process measures as well as outcomes measures. So we
Hmm.
were looking at how many interactions the virtual nurse was having with the patient on a daily basis. We were looking at how much time were they saving the nurses at the bedside. And so, what we saw pretty succinctly is in 2 units, we were saving about 150 hours of work for the bedside nurse every single month, taking that work away, having a virtual nurse do it through that work. We saw our completion percentages of, admission paperwork, discharge paperwork, patient education, all dramatically increase. Small changes in length of stay, patients getting out the door a little bit sooner and after the discharge order was written. We saw patient experience scores jump up,
Wow.
and then really saw again, when you look at these databases, they're pretty tight bell curves, and so small improvements had a very large percentile rank improvement. Ultimately, we tried to do this in a way that we were designing the system so that when we're adding additional cost, meaning we were using the same nursing hours per unit of service to achieve that work, just arranging it differently.
Wow. Sounds like some really nice improvements across the board. Did you all, or it may even be too early, any impact in terms of extending the clinician's time in the healthcare system too? Are you seeing any impacts there?
Yeah. So I would say that's more anecdotal at this point, but what I would say is I've been doing this a long time and have a lot of different change projects. I have never had one where universally you walk in, you ask the nurses how this is going, and the feedback has been, "This is the best thing you've ever done." When we were in a pilot phase, the conversation from the other units was, "How soon can we get this?"
Wow.
Because they saw the value to it. We kind of set our model up in a hybrid model, meaning we do have some team members that are full time doing working in the virtual role, but we actually have a number of team members who are working maybe 2 days at the bedside, 1 day in the virtual role, or 1 day in the virtual role, or vice versa. And ultimately, the feedback from them has been it's so nice. One, it gives them a break, right, from some of the physical demands. It allows them to work a little differently, have different kinds of
Sure.
interactions with our patients. And the benefit to it is these are the same nurses that work with our patients and our physicians all the time, so they still know each other, and they still have that level of trust because they work in at the elbow with them as well. So it's been I think a really good model to start. We're now fully deployed across our first hospital and working on the next one. And I think what we're trying to be very intentional about is that each one of these go lives is going to be one of one when it comes to a change management process. We don't want to just assume that because we did this in one site with one team, that we can just say, look, it works great over there. You do it too. So we're trying to be very intentional about making sure that we work through that change process with each site as we go live.
Wow, it's a very thoughtful, deliberate point of view, and that probably makes all the difference in the world, the one of one comment, as opposed to thinking each and every single system looks exactly the same. So maybe the last question I'll have for you today is sort of just sounds like great progress in terms of rethinking the workforce through leveraging virtual solutions. What about AI? Any other thoughts from you as far as AI and maybe the impact that it has on the clinician workforce?
Well, that's the great thing is, and as we've talked about, like, so this kind of new model of acute care, we know AI has got to be a piece of it too. The first use cases that we're bringing live are actually being able to use the sensor that's in these cameras in a room to do things like bed exit alarms, so that we don't have to have a sitter sitting there. We've
Yep.
obviously spent a lot of time thinking about, the safety of our team members and the world in which we live and, having the ability of the AI in the room that's there listening to understand when, things may be escalating and being able to call for help without somebody having to find a button or pick up a phone. We've talked about, it's Henry Ford Health. We've talked about having keywords like, "Hey, Henry," to activate a series of events through the
I love it.
speaker and the AI. So I think we're in the early phases of starting to implement some of those things. But certainly, I think this is where the future is. I'm really excited that within the next 12 months, we're working toward I'll call it the golden goose of nursing, which is, can we actually do voice activated documentation by using the tools in the room, right? Having that ability that some of our physicians now have, but actually doing that in the nursing space. Still true, right? Nurses spend 80% of their time doing documentation. And so can we use the AI to take that burden away? And so I'm really excited. Again, I think the future is limitless in this space. We're only bound by what we can imagine or what we can try. So having a team and teams that are willing to try out some of those things is going to be really key as we go into the future.
Sure. Well, Eric, thanks for stopping by today. I really enjoyed the opportunity to catch up and learn a little bit more from you about how you're transforming the workforce at Henry Ford.
Absolutely. Thank you so much for having me.
Thank you for joining us today on Elevate Care. If you found this episode valuable, please consider sharing it with a colleague and subscribing to our show on your favorite podcast platform. You can learn more about this episode and our show on our website at amnhealthcare.com, and follow us on social media to stay updated on new episodes and the ever-changing world of healthcare.